Hello. In this video, I'm going to review the current state of knowledge on reproduction in transgender men on hormone therapy and identify gaps in knowledge. Let's start with a case to set the stage. In this case, we have a 24-year-old G0 transgender man who presents to your clinic for initiation of testosterone therapy. This patient has been living as a man for the past 6 years, has a completely negative past medical, surgical, and GYN history, and is having regular menses. He's engaged to be married to a cisgender man, and they would like to have genetically related children with a friend as a gestational carrier, maybe 7 to 8 years from now. You discuss the process of IVF, including costs, and he tells you he would need to use all the money they've been saving for their wedding if they want to pursue IVF. He wants to know, is it really worth it to do it now, or can they wait until they're actually ready to have children 7 to 8 years from now and have been able to save money again? What do you tell him? Well, what do the medical societies recommend? The World Professional Association for Transgender Health states that healthcare professionals should discuss reproductive options with patients prior to the initiation of medical treatments for gender dysphoria. Similarly, ASRM and the Endocrine Society have published guidelines recommending fertility preservation counseling, again, before starting therapy, and ASRM takes it a step further and cautions that patients should also be counseled about the lack of data we have on the effect of gender-affirming hormone therapy on future reproductive capacity. So how bad is that lack of data? What data do we have? Qualitative and survey studies have demonstrated that approximately 50% of transgender adults express a desire to have children. This is in contrast to studies of adolescents, which have shown much closer to only 25% express a desire to have children, suggesting that there is potentially a change in their mind as they grow into adults. When asked if they would ever consider egg freezing, about 40% of transgender men said they would. Interestingly, transgender men with children score better on mental health scales, and transgender women with children have a lower suicide risk compared to their counterparts without children. And while I feel we shouldn't have to say this in 2018, I've been asked enough times that I feel the need to include that we have absolutely no evidence that having a transgender parent results in adverse outcomes in long-term psychosocial functioning for the children. There's also a single study on transgender men who have experienced pregnancy that showed 84% of subjects who had live births were actually on testosterone before and used their own eggs. 32% of the participants in this study actually conceived while on testosterone unintentionally. And importantly, there were no difference in perinatal complications in those that were previously on testosterone compared to those that weren't. It is important to note, however, that this study selected for transgender men who had live births, and thus does not include those with difficulty conceiving or carrying to term. Additionally, 64% of the subjects on testosterone therapy had been on testosterone for less than 2 years, so results may not be as reflective of the effects of long-term testosterone on fertility. The only data we have on fertility preservation in this population is from case series, 2 of which describe fertility preservation outcomes prior to starting testosterone, and the third is a qualitative study in which only half of the participants were on testosterone prior to fertility preservation. Importantly, in the first fertility preservation study, 2 out of the 3 patients have returned to use their eggs with a partner carrying the pregnancy. In the qualitative study, the majority of participants found the resumption of menses from decreasing or eliminating testosterone and increased estradiol levels to be psychologically distressing, although there was a minority who commented that it was not as distressing as they had expected. In this study, regret was not assessed, nor were medical outcomes. There have been a variety of case series describing histological changes noted in the ovaries of transgender men on testosterone therapy, many of which are displayed here. The majority of these studies describe a classic PCOS-like appearance, but some of the studies present a less concerning picture. The quality of these follicles is largely unknown. Limitations of these studies include their observational nature and the fact that they don't control for testosterone regimen or serum testosterone levels, or GYN history, which could be significant given the higher proportion of transgender men with PCOS. Finally, the average duration of therapy in all of these studies was less than 4 years, making it unclear if the results can be applied to a population who has been on hormone therapy for much, much longer. Some have suggested that we can extrapolate outcomes from data on women with PCOS or mouse models of androgen administration, most of which are also to study PCOS. I would argue that hormone therapy with testosterone is not the same as the multifactorial pathophysiology of PCOS, and thus fertility outcomes and transgenerational effects should not be compared. The PCOS animal models initiate testosterone prenatally or in the prepubertal period, so also should not be applied to gender-affirming hormones, which are generally started in the postpubertal period. There are also some mouse models on susceptibility to malaria in which testosterone was administered to postpubertal female mice, and these studies indicate persistence in epigenetic changes and gene expression even after testosterone is stopped, but none of these studies examine reproductive outcomes. A recent mouse model mimicking transgender hormone therapy did look at bone health, but the ovaries were removed in that model and thus could not study reproductive outcomes. As such, multiple questions and gaps in knowledge remain. First of all, there is likely a gap between the percent of transgender men who said they desire children and those who actually have them. And we need to figure out if that's because we are not offering adequate options to these patients. The studies that we do have in transgender men are limited in number and timeline, and they're not controlled for GYN history or testosterone dose or duration. And most importantly, they have conflicting data on outcomes. There are currently no standards instructing clinicians on how long testosterone needs to be stopped prior to stimulation and whether testosterone even needs to be stopped at all. And finally, to my knowledge, there's absolutely no data on the effect of puberty blockers or testosterone administration in adolescents on future fertility. Given that most randomized controlled trials would be unethical, it is important to continue to publish ART outcomes in transgender men and for institutions to pool data. A multi-institutional database is being developed to try to address these gaps in knowledge. We also need animal models directly relevant to gender-affirming hormone therapy to study reproduction. The ultimate goal should be the ability to provide evidence-based counseling to transgender men seeking fertility care both before and after initiation of gender-affirming hormone therapy with testosterone. Thank you.